Melflufen is a very interesting new agent in our myeloma armamentarium, in my opinion. Just to give our audience some background, it's an aminopeptidase activated drug, which is essentially derived from an original alkylator parent, with melphalan obviously as its background, but it would be a mistake to think of it as a sort of glorified melphalan. That's really not what it is. It is aminopeptidase activated, which means it's directly delivered to the tumor cell and held within the tumor cell by virtue of this aminopeptidase activation. Just to share that aminopeptidases are a very important oncologic target. They're heavily overexpressed in tumor cells and in myeloma in particular. That results in this drug having substantial selectivity. It is very much a lipophilic drug, which means it goes to the marrow, so there is indeed some myelosuppression, but at the same time it's very strikingly favorable in terms of an absence of off-target non-hematologic toxicity. It doesn't cause mucositis, it doesn't cause alopecia. So because of those properties, it's particularly attractive, I think, for our patients in terms of being a targeted cytotoxic. So we might say, well, where does the place of a targeted cytotoxic in myeloma belong? It's very interesting. There are some clues there. We definitely see in our practice that the revisitation of cytotoxic chemotherapy during the course of a patient's disease can be helpful. And in terms of clinical trials, there were the results of the FOCUS trial some years ago, which was a randomized comparison between carfilzomib and cyclophosphamide and steroid-based approaches. And amazingly, that study showed there was actually very significant activity, in fact, in that study from the cyclophosphamide-based combination. So that's a clue that there is a subpopulation of patients with relapsed refractory disease in whom cytotoxic therapy may be helpful. Because in that study, as you may know, carfilzomib actually did not outperform the control arm. So with that in mind, it was particularly attractive to us to see the preclinical evidence around melflufen, which showed that it was able to be very active in myeloma that was resistant to melphalan, a key first experiment, then to show its activity in other myeloma models that would otherwise be resistant to some of our available agents, including proteasome inhibitors, and at the same time to see relative safety in terms of preclinical testing, and furthermore in vivo models to see some potent effects. And those potent effects included not only clear evidence of being able to overcome classically resistant cell lines explanted into these tumor models, but at the same time to show interesting properties like anti-angiogenic effects, which is somewhat distinct to what you'd normally expect from conventional chemotherapeutics. With all of that in mind, our early phase studies had established a dose of melflufen of 40 milligrams infused every 4 weeks with dexamethasone as an important partner. But it's important to recognize in those studies these were dex refractory patients, so the role of dexamethasone wasn't the reason that we saw the signal, which is always important to emphasize. So with that initial studies being done and showing the benefit of this approach, the Horizon trial has been a next step, but into a very defined relapsed refractory patient population of exquisite unmet medical need, patients who were both refractory to Pomalidomide and Daratumumab, and also enriched for extramedullary disease. So at this meeting we're presenting data on this very large international study. At ASH last year we presented data on approximately 80 patients. We will be presenting data at this meeting on over 120. And what I can share with you is we've been very pleased to see a sustained response rate, approximately a third of patients responding, approximately 45% of patients enjoying clinical benefit, i.e. minimal response or better, and stabilization of disease in a further 20% or so. So for such a relapsed refractory population to see a once-a-month infusion generating that kind of response signal is encouraging. Approximately 2/3 of the patients have high-risk cytogenetics, which in itself is very ominous, but what's very striking is the number of patients with extramedullary disease and seeing a signal in that population. So if we look, for example, at the triple-class refractory patients with extramedullary disease, very poor prognosis population, we're seeing about a 30% response rate in that group. Now if that's sustained, recognizing this is preliminary data, that's very important, because if you look at studies of extramedullary disease, especially in Daratumumab and Pomalidomide naive patients, the best we've seen is between 10 and maybe 20%. Recognizing these patients are both Dara and Pomalidomide refractory, to then see a response rate recognizing that this is early, so we have to be careful. But if that's sustained and real, that's remarkable, and that suggests we really have a new direction in which to go. So, and very important data in that regard.